Okay. Good afternoon, everybody. Hello and welcome to the Greater Manchester Stroke and Neuro Rehab webinar. My name is Farheen Akhtar and I am one of the facilitators with the network. Today our webinar is on upper limb recovery, which will be very kindly delivered by Ulrike. And just to go through, just prior to starting, we'll just go through some housekeeping. As you all know, you're all muted. You will be able to ask questions through our Q&A panel to the panel at the end through the Q&A box, so you feel free to post any questions throughout the webinar. A recording of the event and certificates will be emailed out to everybody afterwards. We will ask you at the end of the webinar to evaluate us, and please, if you're enjoying the webinar, please tweet us at GMNISDN. Any of our future events will be future events, and our previous events are all on our website. And our website, I will upload a link into the comments box. For any other inquiries or details, please do email Lisa. And without further ado, I'll let Ulrike take over. Thank you.
Hello, everybody. Just trying to get the slides up. Right, can you see these now? Can you see these now, Farheen?
Yes, we're good to go, Ulrike. Thank you.
Perfect. Thank you very much. So, hello, everybody. Thank you very much for coming today and giving me the opportunity also to the ISDN to talk to you about upper limb recovery after brain injury. So today I'm going to talk a bit about what can therapy achieve, or really what are our limitations probably that are limiting kind of effectiveness. So why we, what we're going to talk about is first about really the kind of like the need of research of arm recovery after stroke. So why do we need to do more? And then also kind of like the importance of actually understanding why there is recovery, or why maybe there isn't recovery at times as well. So to that extent, I'm going to firstly talk about the corticospinal tract and the importance of the integrity of that and how we can measure it. And then also a bit about other tracts. So particularly here, I'm going to talk about the reticulospinal tract in recovery. To kind of end off, I'll just talk about other predictors really that are important for it. So we know that upper limb recovery is very, very common. Upper limb weakness after stroke is very common. So 60% of stroke survivors actually have got arm weakness. So we can see there the red portion. But even at the end, after a long time, 1 year after stroke, 20% of stroke survivors cannot use the arm in function. The size of this is huge, therefore, the problem, because if we consider that 100,000 strokes happen every year in the UK, and thereby 20,000 of those survivors actually can't use their arm in function. Now, the worrying thing is that current interventions are actually not changing this proportion. So the call by the Stroke Rehabilitation and Recovery Roundtable was therefore that we really need to understand why we don't kind of like have this recovery, or how we can get recovery in some survivors, so that we actually know which survivors should be treated by which intervention, so that we can target the available structures and yeah, kind of like thoughts. So I don't need to speak to anybody here, I suppose, that's attending about the importance, of course, of neuroplasticity for recovery. So this is twofold. One is that actually we know that neuroplasticity can be structural, where we actually get changes in the structure of the nervous system, but it can also be functional, where actually we just get better functioning, better ability to perform movements. But all of this, of course, requires high repetition. So the question is a bit how we can actually investigate this in recovery after stroke. So one is, of course, we're trying to get as good movement as possible. So in this instance, we've got somebody who's sitting, they're looking down on a mirror. Above that is a screen. So when they look down at the mirror, they can see a target like depicted on the right-hand side here. So they can see a target and they can see a starting box. So what they then do is they perform reaching movements to the target. Now, to get the best movement in here is that we actually have people, so the forehead is supported so they can't move the head. The shoulders are kind of kept in position. And then we actually support the arm, because if we think about stroke survivors, they're very weak, so they couldn't do a high repetition. So what we ask them to do is then attend multiple days to perform this reaching to these targets. And what we aim is on training days for them to reach over 400 times to this target to actually get this learning. So what does this kind of like treatment give us in understanding the mechanism? So if we think back of that kind of like individual performing those reaching movements, if we would think about all these different movements to the target, we can see that there's this scatter. So the round area here is the target, and then we've got this scatter of where people ended their movement. Here's the starting box. So we can see that actually there's a bit of a bias in here. So as an example, again, so we've got the start position at the bottom here with the target here at 0, 0. So this is one individual. And what we can see is that before training, they ended all their movement a bit short and a bit over to the left. When we then looked after training, they were actually right in the middle. So they were able to change that bias and actually to now reach to a new target. This is a different individual, and what we can see is that in the beginning they were all very widely scattered around the center point, and after training on the red dots they're much closer to the center. So what has happened here is that they haven't had a bias, they didn't change a bias, but they just became much less variable, much more accurate at the movement. So this was a paper. So, and what we actually did here is we had 38 stroke survivors. And what we found is that actually in these chronic stroke survivors, as an average, they didn't change bias. So they didn't learn anything new as in learning to reach to a different target that they couldn't reach before. But what they just became is less variable. So actually they became better at doing what they could do already, so to say. So we can further explore then also kind of like how they learn over time. So in this example, these are now all of our stroke survivors, so 38 is an average of them, on the 4 different days. So each day is where they perform 420 reaches. And what we can see is that we train people at a bit different speed. And we can see the blue line actually from start to the end, they had an error of their reaching. So they kind of like didn't hit the target very closely. And over the 4 days, there's this gradual decrease of the error so that they actually almost is half the error at the end of the training. Now, what we can see those on a day-to-day variation is that they, in the beginning, they improve very rapidly. And then we've got the dotted line that shows the end of the first day. And then by the next day they come, they've forgotten a little bit. And then they relearn quickly again. And at the end, maybe a bit of fatigue, and then they forget again. So this kind of like just shows then also how the learning happens from a day to day. So we would know in this, for example, it appears that on the blue line that the learning hadn't finished yet. We haven't plateaued. So potentially going on and doing longer training would even change that further. So that's kind of like some of the thoughts of how we can understand really the mechanism of learning, and to actually see also what do people really kind of learn, what do they get better in. Now we here actually wanted to look at also in the same kind of like group also at the corticospinal tract because we know that it is very important for recovery. So the corticospinal tract has been investigated extensively, and really, so what we've got here is the red area, the M1, and we know that the corticospinal tract, here indicated by the grey line, kind of like descends and then crosses over to the other side and actually innervates the most of our dexterous movement to the opposite side of the body. Now, the importance of this to movement and to recovery has been long established by Lawrence and Capers in the 1960s, and then also by Lemon, and a lot of this work was actually originally performed in animal studies. Now, if we think a little bit more what we know about the corticospinal tract and how we can investigate it, it is actually very easily tested by TMS, transcranial magnetic stimulation. So what that is, here's somebody holding a TMS coil over the motor cortex. And what happens is that a very rapid magnetic field is induced, which induces an electric current in the nervous system. If there's sufficient electric field, it depolarizes the nervous tissue underneath, which causes the neurons to fire. That generates an action potential. And then what you would see is in EMG, you can detect this motor evoked potential. So in general, it doesn't penetrate very deep. There are some safety issues related to it, but actually quite simple. One is its magnetic field, so anything to do with metal implants, pacemakers, anything like that. And then there's this very slight chance that it could actually induce an epileptic seizure, not so much in single pulse as used here, much more when it is used therapeutically. So just to kind of like demonstrate also why it is so easy to use it is really because, of course, we've got the motor homunculus in M1, so depicted here on the right, which makes it very easy to actually assess and analyze any hand movements because of the large size of the hand representation in the motor homunculus. Bit harder for the leg and the feet, which are kind of deep in the brain. So just as an example, so we've got somebody sitting, we're holding a TMS coil. This is the machine, so it generates the pulse. And I'd like you to have a look. So we've got EMG leads, electrodes on the hand here, first dorsal interossi. So when we actually then kind of like perform a stimulus, you can see the little twitch in the finger, maybe again, see a little twitch. And then what you can see on a screen is that we actually can depict here on immediate feedback on EMG. So you've got silence before, this is the kind of like the artifact noise. And then here we've got a huge motor evoked potential. So this is exactly when we then actually perform. So we stimulate the hemi-brain, so we can see that there's the stroke on the side. So this is, we're stimulating the left side. This is the left triceps. We can see there's no activity here, but actually we see on the opposite side here on the side that actually we can see after 20 milliseconds, 25 milliseconds, here is then the motor evoked potential. So this is an overlay of 20 EMG traces. So how to then kind of like look at really how the corticospinal tract affects recovery after stroke and the ability to learn. So this is a study that we performed. We were based at Salford Royal and recruited actually from all over Greater Manchester. So I suppose a few people on the call would have helped me to recruit to this study. So we recruited stroke survivors 3 weeks after stroke, and at that time we performed an assessment on all. We then randomized them into 2 groups. One received 6 of these 400 movement arm training sessions between 3 weeks and 6 weeks. The other were the control group. And then we reassessed them at 12 months. So again, kind of looked how they performed. And the group that was in the control group was offered the training after the 12 months, the 12-week or the 3-month assessment. So what we did in these assessments is that we actually kind of like we looked at how they could perform the skill, so skilled reaching. We looked at their muscle strength in their arm, and we looked at also what is synergy expression, or the ability to kind of like move the hand out of synergy, which is the Fugl-Meyer upper limb score. In addition, we tested what happened if we stimulated the hemiside. So we could then kind of like test the strength and the integrity of the corticospinal tract to their weak arm. And we also kind of stimulated the unaffected side to actually see if there were other connections. I'll talk about that in a second. So exactly, so same setup, 400 reaches for 6 training sessions in between here. So what we then kind of found is that these are all kind of like, so Fugl-Meyer at the base and then at 12 weeks. So what we can see is that the Fugl-Meyer and the metricity index, if we just sum all of these up, improve. So at base, it's less, and then at 12 weeks, we have the natural recovery. Now we divided these kind of like all the individuals that we can see into 3 groups. The yellow are the individuals where we could not find that the integrity of the corticospinal tract was absent. So there was no corticospinal tract connectivity. The light green is we stimulated and there was some connections, but they were weak. Where the green is actually that the strength of the affected, or from the hemiside, from the stroke side to the weak arm was similar strength to the strength of the intact connections. Now what we could see is that actually this very clearly, these 3 divided our Fugl-Meyer and our metricity index into these 3 groups. So the strength of the corticospinal tract influenced the baseline. However, then statistically, they all improved to a similar matter. So they all got better irrespective of the corticospinal tract integrity, but definitely it affected what they could do. So this is very much in line with the work from Kathy Stinier. So I don't know who of you have heard about the PrEP algorithm, and although it's very complicated if you look at the bigger picture, it really starts from a quite simple kind of like thought. So what they did is they start and they perform the SAFE score. So the SAFE score is a score that's been out for over 10 years. It's from the Cortical group. And it is, the SAFE stands for shoulder abduction, finger extension. So it's 2 tests, really MRC tests. And what they said is that if people on doing an MRC, which kind of the maximum would be have 10, so 5 strength in the shoulder abduction and 5 in the finger extension, if at day 3, people would have 5 or more in the SAFE score, they would then kind of like be in a different kind of like prediction of outcome than if they had under 5, so a 4. So if we think about a SAFE skip of 5 or more, so even if they only had full shoulder abduction, you would go into the top score, or if you had kind of like strength in both, in any kind of like shape, or of course the finger extension. Now, if you now had over 5 in the SAFE score, and you are under 80, the prediction is that you're going to make an excellent recovery. Whereas if you are SAFE score over 5 and you are over 80, sorry, then it really depends. If your SAFE was under 8, so you've got probably kind of quite significant weakness, so 7 or below, then you're likely to make a good recovery. Where if it is over 8, over and equal 8, then you still are likely to make an excellent recovery. So the strength really here determines a bit. However, if your safe is kind of over equal 5, is under equal 5, so is 4 or below, then they use a motor evoked potential to determine if you could still make a good recovery or if it's going to be limited or poor. So the MEP here is, as I say, so if you stimulate with TMS and you can see a reaction on your weak arm, then despite the fact that you're very weak and you can't move, there is clearly enough of corticospinal tract integrity available for you to actually recover. Whereas then kind of if you do not have an MEP, then it depends a little bit on comorbidities. If you've got actually quite few additional factors on NIHSS that would affect your outcome and maybe your ability to learn, you likely make limited recovery. Whereas if you actually have got lots of other things, lots of other points that you're losing on the NIHSS score, then you're likely to make a poor outcome. So quite complicated, so we can speak to it about later as well if it would be needed. So moving on then from the corticospinal tract is like, what happens though if people do not have a corticospinal tract? Are there actually any other tracts available? Now I'm going to talk about the reticulospinal tract because although we're starting to know more about it, there is actually quite a bit of controversy about it as well. So when we showed this in the beginning, so we only highlighted at that stage from the red area here, the M1, the grey tract going down. But if we think about this now, if we only look at the kind of like really at spinal level, and we can see that here, all the kind of connections that are descending onto the right, well, actually it's the right side of the screen, it's the left side of the body really, but on the right side of the screen. And we can see that quite a few of these connections actually come also from this indirect connection on the right. So from the PM, so the primary motor, the supplementary motor area, and the, oh, I didn't actually now. Yeah, so the prefrontal motor area, exactly, prefrontal motor area and the supplementary motor area. So, and these connections actually go ipsilateral, so they go to the same side to the reticular formation and to some extent also to the vestibular nuclei. So the idea is here that actually if somebody would have a stroke where the red area would be indicated, then maybe these other connections could actually help in recovery. So what we know from the reticulospinal tract is, one, that it innervates proximal muscles. And it does this because it actually, when it descends and when it onto the motor onto the level, it actually does it on multiple levels. So it doesn't, like the corticospinal tract, doesn't only kind of go to a single motor neuron, but it often kind of spans, say, even the cervical as well as all of the thoracic, sometimes even also lumbar areas. So it kind of causes much more of a generalized, less fine grain activation. But as I said, if it is really kind of like can be helpful for recovery is not so sure, and there's some thinking that it actually might be part of the reason of actually the emergence of maybe motor synergies and unwanted patterns. What we do know now is, however, that this kind of like additional role is not from kind of like ipsilateral corticospinal connections. They play very little role, if any role, actually in the recovery. So now thinking about what we did here is, as I said, so we actually stimulated one on the top line here, the affected side. We expected to have a cross reaction, and in this example we can see that the weak right triceps in the top line, actually we can see MEP. Now we're stimulating the left side, so we the right side here, and we would therefore expect normal connection to the left, So there's actually kind of like the strokes on the other side. So this is an unaffected pathway. And we can see that on the left side here, that there is a reaction and a motor evoked potential. However, what we can see on the right panel at the bottom here is that actually when we stimulate the right side here for this individual, they have got kind of like ipsilateral responses in their weak arm from stimulation of the unaffected hemisphere. So the real question is, if we would kind of look at this and correlate that people that have got this reaction or this kind of like connection, can we thereby see that these individuals actually have got better recovery or worse recovery? So we kind of, as we said, we looked in the top panel, we looked at the corticospinal tract. So what we then did is in the bottom panel here is use the same kind of measure and just divide all these individuals and say, in the grey is all the individuals that had both a reticulospinal tract and intact corticospinal tract. And in the bottom one, we've got the individuals who only have got a corticospinal tract. So what we could find there actually is that it made no difference at all in these individuals. So the type of connectivity for these individuals did not influence either the baseline or how they improved over time. So what our finding was, therefore, for this paper is that the strength of the corticospinal tract, not the reticulospinal tract, determines upper limb impairment level and the capacity for skill acquisition in the subacute post-stroke period. Now, this is quite important, the subacute period, because that was really the thought of, is this something that is maybe available that we can work on? But it appears that in the subacute, so early at 3 weeks after stroke, it really, what is important is just that if the corticospinal tract is available, and that is really what can help us with the recovery. Now, to this extent, actually, there's just a little bit of work ongoing. So this is really the first kind of thoughts of this, rather than particularly kind of like a detailed analysis. But what the question is, if we could actually have some individuals that have got the reticulospinal tract available, and if we could upregulate it, could we actually then thereby make it helpful for the recovery? So this is a study that was done in 95 stroke survivors in the chronic phase. So what they did is, so the reticulospinal tract actually is very kind of excitable by loud click sounds. So by a loud click sound, you can actually kind of elicit more excitability from the reticulospinal tract. So what they did in this study is that they've actually had stroke survivors, and they used an electrical stimulator that was placed with electrodes onto the wrist extensors. And they, for 4 hours a day, delivered a click sound in the air at the same time as wrist extensor stimulation at a certain kind of like frequency. And what they found is that in these individuals, actually, that the paired stimulation compared to their control improved these individuals' ARAT score. Not huge differences, not great functional, but there was a change in it. So just to kind of come back to my point in the beginning, it's really early days to look at this, but this might be something that if we could actually kind of use this stimulation kind of after stroke, it could be that we could help people with more severely affected, where the corticospinal tract might not be available, and we might be able to get some improvements in the like functional measures, like for example the ARAT score. So I kind of talked now about the fact that these two tracts, so the corticospinal tract, absolutely vital for our normal movement, and then that, of course, the reticulospinal tract may be something that we can target further in recovery. But we do know that it's not only about the tract availability as well. And I think this kind of comes back also to the PrEP algorithm that indicates that it also depends on what other measures on the NIHSS score, or kind of like what other impairments are impacting recovery. So now I'm just going to talk a little bit almost about actually some work that we did in the previous couple of years or few years, in which we particularly looked at various parts of kind of predictors of recovery. So this is again the study where we actually looked at and asked people to perform these reaching movements, chronic stroke survivors. So if we look at this kind of graph in the bottom, so this indicates the different individuals, and we actually show their error, so how inaccurate they ended on the movement, on the target as an average per individual. Oops. Now, if on the x-axis in the bottom, we've got how they were before training, and then the y, we've got how they were after training. Now, if the line, the red and the blue line, would be on the dotted line exactly between the two, that would show that the error didn't change. If the line goes underneath it, it shows that at the posts on the y-axis, there's a reduction, so there's an improvement in error. So what we can see on these two lines is that they both, dependent on whether they were training fast or slow, they both reduced their error to the same extent over training. Now then we kind of looked as like, okay, if we would now say we'll input different kind of like or kind of like split the groups depending on different impairments. So we first looked at sensory impairments, and what we can see is that the grey is mild sensory impairment, and what we think about of how the graph looked before, that looks quite similar to both our training groups. So we get quite a significant improvement in the error from training. When we then compare to people who had moderate sensory impairment, we can actually see that is on the dotted line. So people who have had moderate sensory impairment in our group did actually not improve in this. We performed the same for, I say here, mild spasticity. It should be hypertonus because we used the modified Ashworth scale. But what we can see here is that it actually didn't make a difference whether people had mild or moderate hypertonus on the modified Ashworth. They were very similar. And then in the last group, it's a bit harder to see actually here, but so the black line indicates people who had significant weakness. And what we can see is that people with significant weakness actually made a lot of improvement. However, with people with very mild weakness, we actually didn't see that. So it's a very small line, it's on the bottom, but it is actually very close to the dotted line. Now, it's a bit surprising, but actually, probably on this paradigm that we performed, where people were able to perform this movement on the weight-supported system, this was probably actually particularly good for people who have got some weakness, and people that are very mild weakness might actually have been performing even before just about at their level. So it is really much more designed to help people with disability.
Hi Ulrike, just coming up to 10 minutes approximately.
Okay, thank you, Lisa. Good. So we then looked at the next thing, and I think we all are aware really of the importance of spatial neglect and inattention for stroke survivors' recovery. So in this week, we did a big assessment of the SNAP database. So if we look here at the whole sample number on the right of the table, we can see that there are 88,000 individuals that were actually included in this database. So we did a couple of things. We first wanted to see, and this is really taking measures from the NIHSS in SNAP, and we looked at how many individuals actually did have neglect. So, and we can kind of look at the finer details, but we were surprised at how common it was. Now, there's some striking findings here of when we look at the length of stay for survivors in day, if people had no neglect, their average length of stay was 10 days. Where for individuals who did have neglect, it went up to 27 days, so almost 3 times as long. So the modified Rankin scale outcome, where we just dichotomized either into people that were independent, so it was a 2 and below, or if they were dependent, say 3 to 6, we actually can see that individuals who actually had no neglect, there was still 57% that were dependent on discharge, but in individuals that had neglect, that went up to 76%, so a huge extra proportion. And the same with death. So only 8% died after being admitted with stroke with no neglect, but 23% died who did actually have neglect. So just as a kind of like, there was a poster we presented on this, but really if we kind of come to the main points of it, is that if we look at the kind of like the chart here of how many individuals did have, so it is very common, so 30% of stroke survivors actually in SNAP dataset are admitted with inattention or neglect. It is seen much more in severe stroke survivors. So in individuals who have a severe stroke, as kind of like measured with the NIHSS, 84% have got neglect. And then it is, as we said, associated with the increased length of stay and with worse outcomes and dependency. And of course, that affects the outcome in general, but it also then, of course, affects our outcomes in arm recovery. Now, another aspect that actually we probably are not kind of looking quite that much at is actually the importance of type of stroke for prediction of outcome. So if we think about the 2 types of stroke, intracerebral or intracerebral hemorrhage or ischemic stroke, there's here we just got 2 kind of like figures up of it. And of course, although to some extent they come into the hospital looking the same, what happens in the brain is very, very different. In the one, we have got ischemia, which causes cell death, but in the other, we have got actually a blood clot, and blood is very kind of toxic to brain tissue and actually causes a whole kind of cascade of further events that leads to a very different time frame of recovery as well. So as we said, so weakness is very common after stroke, but if we would kind of like ask, if I'd ask any of you, or if we've asked people, clinicians before, if they think that arm recovery is the same after ischemic stroke and ICH, I think I often hear people don't think so. So therefore we thought we'll just have a look at the literature. And actually, although there is some outcome or some measures of how people kind of like their outcomes are on the modified ranking, how dependent are they after either the one or the other type of stroke, there's very little information about how motor recovery differs between the 2. So we did a systematic review. And in the end, we only could include 3 studies that all measured a form of motor recovery. We used the Fugl-Meyer assessment, all kind of like performed assessments before 30 days and repeated the measures later. and also gave us some information of the measures separately for stroke, ICH and ischemic stroke. Now, just to kind of sum up, so all the dotted lines are for intracerebral hemorrhage, all the solid lines of ischemic stroke, and we've kind of kept the colors consistent for the 3 different studies, just because it's quite difficult to compare them because we haven't got the same data times or time points. But what we can see is that for all of the studies, the dotted lines are lower for the same color than the others. So the ICH survivors have got a lower Fugl-Meyer score at baseline. And if we then look later, either roughly at 12 weeks, so kind of like here, or we look even how long data we have, it looks that by the end, actually, the ICH survivors have caught up in the recovery. So we just kind of believe that there's really a need to investigate this a bit further and just really get a better understanding of the differences in the recovery. Oh, I just realized there was one missing, but there we go. So one other thing actually about the ICH patients is that there are some very clear kind of like markers that actually indicate also how individuals actually recover. So this is again a systematic review where we looked at all predictors of outcome measures, and don't need to go into too much difference, but so these are forest plots, so they actually kind of like then indicate per each marker really the final significance of indicating outcome. And actually what we can see is that the only markers that we found here that were not actually predictive of outcome is the systolic blood pressure at baseline, as well as then actually here, so CT hyperdensity. So that's actually, if you can see that there's kind of like further bleeding happening in the hematoma. Actually also they're here, the location, so infratentorial, so lower didn't, so infratentorial strokes didn't identify a particularly marker for outcome as well. But it's just there's some very clear things, predictors that we know that will influence our outcome: age, if there was any pre-morbid disability, and then of course how people present at baseline as well. So just to kind of then sum up, so basically just been talking about the fact that upper limb weakness is extremely common after stroke and that it recovers poorly, that we can actually use measures of the behavioral change as people kind of like performing movement to understand how they've learned anything and if it is something new that they've actually acquired. We can, I talked about the importance of the corticospinal tract for recovery, and that although we know that reticular spinal tract at baseline does not influence early impairment, that there might be actually a marker there or a system there that we can also kind of work on for recovery. And then I just also kind of talked about the fact that sensory impairment, neglect, and the stroke type can actually predict recovery for these individuals. So that is all that I wanted to say. Just want to actually also say that please get in touch. I've got my email on there. I think it might be on the chat as well, but I'm happy to hear any other questions if there were some outside of this forum. But then also I'd like to actually thank all the stroke survivors that have been participating and attending the lab for multiple sessions. And then here's a list of collaborators at MMU, at the University of Manchester, and then the funders that have actually supported the work. So that's that for me. Thank you.
Well, thank you very much, Ulrike. I have a question for Ulrike. What do you think, if you find a patient that has complete damage of their corticospinal tract, what does that mean for arm rehab, and should this patient get treatment?
Okay, yes. So the whole idea about the corticospinal tract damage, so specifically for, and this is kind of relates to the PrEP algorithm, I'm sure, is that if we think about how people recover differently on the PrEP algorithm, it is probably the only people that really need very little on rehabilitation are the individuals that have got over 5 and over on the PrEP score and are younger than 80 years old, that are going to make a fantastic recovery. And I think it is anybody that kind of like has probably got a lower recovery or that has got no recovery that needs then to actually have specific treatment. But I think where the PrEP algorithm becomes really important is to dividing and thinking. So for people that have a corticospinal tract but are weak, it is a real thing of getting in there and doing as high repetition as you can to maximize that tract neuroplasticity. But if there's no corticospinal tract, then probably rather than actually giving people a lot of pressure and saying they have to perform a movement that they can't, it's the thought about really thinking, how can they look after their arm? How can they kind of support the right movements, make sure that the strength or the length of muscles are maintained, spasticity is controlled. And I would say to them that it really is probably a bit of talking about keeping the system as well as possible, that in future, if anything would change, they then have an arm that they can work on. Now, saying that actually is the group, so Senior group, have done a test where they actually used this PrEP algorithm and looked if therapy was more effective then. And what they found is that actually it reduced length of stay. So I don't know how much it would reduce length of stay if you kind of like would change the treatment, but they've got a whole set of treatment really that they've kind of designed to support actually this kind of like self-management of the hand and looking after the arm and doing much more of a kind of like, yeah, compensatory strategy rather than kind of going for recovery. So are there other questions, or should I could go on this otherwise, but
we don't seem to have any other questions at the moment. Yeah,
no other questions at the moment. Okay, so yeah.
Do the audience have any other questions? They can pose them in the chat box, or you can always email Ulrike as well with any questions that you may have later on. But we don't have any further questions at the moment in the question box.
Okay, yeah, so, and I think that's kind of the important thing. So I think further on that is there is this very kind of like sensitive or difficult dilemma of, yes, you perform then the test, the TMS test, and a patient, and you show actually there isn't a corticospinal tract. So you can kind of in that process take the hope a bit away, because people might have been expecting that something happens, and then you're actually saying to them, yeah, and it is probably unlikely, probably it cannot recover. And I don't know, I think different people work differently. So I'm working with one statistician, and I suppose statisticians are a bit black-white, aren't they? And his complete response was, yeah, of course I want to know. I want to know that there isn't a corticospinal tract, and then I can kind of like set up and I can move from there. But I don't think we often would kind of go to our stroke survivors and say that. But I think it's just sensitivity and actually having therapeutic relationships with people as well. So yeah.
Well,
no questions. Oh man, no. I'll use the moment. I'll kind of like, can I see if I can do another?
Ulrike, can I just jump in there? We do have another question that's just popped through.
Okay.
Not quite sure who it's from. It just says, do you know of any research about recovery of upper limbs post-brain injury traumatic or acquired?
Okay, so Lisa, can you just read that one more time, please?
Yeah, so it says, do you know of any research about recovery of upper limbs post-brain injury, traumatic or acquired?
Yeah, so I think probably kind of like, I mean, there's a host of that, of course. So we kind of like doing lots of that, and I think there's a lot of the studies that have been kind of like published recently often show that it's there's mixed results. So if that is the Excite trial, or I mean there's of course a host of studies, or if we even look at all the kind of like constraint induced movement therapy with repetitive task training, but it's a lot of it kind of like comes up with a bit of a mixed result, and that there are some, in the end, the statistical difference between the kind of like intervention that's being tested and the control is very small, or is even not is negligible, that there is actually no difference in our various interventions. And I think there's a lot of these people like Chad Quackle and Nick Ward and people of the leaders, some of the leaders of Julie Bernard of our field, that actually kind of say that the problem is that we are always not doing this. We're not thinking about what treatment would work for whom. And if we would design an intervention, and we've got some people that have a corticospinal tract and some people who haven't, then of course these two can't have the same strategies. So actually we would end up with a null result, because there's just too much noise in the system, because some can't recover and others can. So I think the real thing for us going into the future of thinking, where is rehabilitation? What is it? Is to think, what are the structures that we've got? What are the limitations? So if people have got such severe sensory loss, they can't perform the same intervention as people who have got just very mild difficulties, or people who haven't got a corticospinal tract. And I think that's the thing. So how we into clinical practice can integrate this. So I know that there's some work looking at integration of the SAFE score, because actually the SAFE score is a very good indicator already of what your prediction for outcome is. So and I think if we can start to integrate these measures and get them early after stroke, and actually see how they can kind of like correlate and help us with conversations with patients, so that we can also help them to have probably realistic expectations. And then also to kind of like show to us of the effectiveness of it.
Okay, thank you for that. We've got a few more which have just popped through as well in the meantime. So the next one is, if we as therapists are manually facilitating the upper limb in rehab sessions, should we be aiming for such high numbers of repetitions as shown in the studies discussed?
Yeah, exactly. I mean, this is our dilemma, isn't it? That actually, when we think about how effortful some of the movements are for stroke survivors, then it's quite hard to think about these numbers. However, it depends what kind of mechanism of recovery we are trying to actually use. If we believe that what we want with our stroke survivors to kind of like how they want to improve is actually that they recover through neuroplasticity, if we don't go to these numbers, that's not going to happen. So neuroplasticity needs high repetitions, and that's why they say over 300 repetitions. And if we just do 5 movements, we might be showing some normal movement, and we might be actually probably kind of like doing something, but actually it won't be neuroplasticity.
Thanks, Ulrike. We've got another question. This one is TMS the only way to establish if no corticospinal tract? Any other way? That's the question.
Yeah. Okay. So it isn't. So but actually it becomes harder. So TMS is a bedside measure. Well, theoretically, it is something that is done in research rather than in clinical practice. Although actually in New Zealand, where Kathy Stinia is from, so they've been using it actually routinely bedside by the therapists. But the other thing is how to measure it is really by DTI imaging, so it's MRI, but it's quite complicated MRI, so it makes it even harder. Now we are working actually, and I'm working with some people at the University of Manchester to see if we can determine by kind of like AI, so artificial intelligence from CT scans, if we could identify it, but it is up to now actually not reliable at all.
Thank you. Another question, just asking about how many exercise repetitions should patients be aiming for on a daily basis per therapy session if the corticospinal tract is intact?
Yeah, the more the merrier. So kind of like, if, of course, it is the whole thing of if we want to have neuroplasticity, and if we believe that either neuroplasticity is either through synaptogenesis or through growth of synapses, or if it is kind of like by improving the whole LTP, so getting better firing wiring, so the Hebb's principle, it is about actually hundreds of repetition, and that's really what we're aiming for. So I think part of that is, of course, then to think also, are there ways that a patient can do it outside of therapy? Are there any other primers we can use for that? There's been various studies actually looking at medication, so fluoxetine, which is really Prozac, to see if that as an addition could help the excitability. But I think another thing that we should really think about is another primer is aerobic exercise. So of course, again, this isn't every stroke survivor, but there are some stroke survivors. If we can get them to be much more active, stationary, bike, arm bike, whatever it might be, that actually changes your BDNF as well. So so brain-derived neurotrophic factor, so your kind of like whole ability to learn and be neuroplastically more adaptable, really. So not an easy answer, but I think we just have to strive for high numbers however we can.
Excellent. So next question is about how realistic is it in the future that professionals will be able to offer patients TMS to identify if they have an intact CST and allow better treatment?
Yeah, I mean, theoretically, if we think about what it costs, so a very effective, quite simple TMS machine probably costs about £15,000. Any neurosurgery for any patient probably costs £15,000. So it's actually not a lot of money if we think about what it would be to a trust. So I think it would be the buy-in of trusts, of actually saying, yes, we would like to establish this, and by this we can actually give better interventions to patients, and we can actually thereby put them in the right stream of therapy, and thereby get better kind of like or help with their expectations as well. So it might be just a thing of like working with people like Kathy Stinia, and if any trusts are willing to kind of like trial it and to go from there, because it is really on the simplest form. I suppose a few people on the call might have seen it because I've done some demonstrations at various places as well, but it is on the simplest form. It is very, very simple with very few kind of like side effects.
Perfect. So we're nearing up to an hour now. I think we'll have one last question. When predicting upper limb recovery, what are the SAFE scores? I think you've mentioned shoulder abduction and finger extension.
Yeah.
Are there any others?
No, exactly. So the SAFE, so that's what it stands for. SAFE is SA is shoulder abduction, FE is finger extension. So the SAFE score, so the paper is Nyland, N-I-Y-L-A-N-D, and it's, I think, 2011, Nyland et al. So it's with Cortical, so he's the last author. So that's the SAFE score. And the idea was that once, if you've got 5 on this, on those as between in the MRC, you're safe to make a good recovery. Where actually, if you've got 4 or less, then you're unlikely to make a good recovery.
Okay, so just one last one. What was the name of the UL self-management program that you mentioned? Maintaining muscle length, etc.
Sorry, the which? So what was the
upper limb self-management program that you mentioned?
Oh, okay. No, so actually, so basically, I didn't really kind of like, but it is so. It was again a paper from Stinia et al, and they kind of like put people onto this kind of self-management stream. So. I think their paper again, so it's Stinia et al, I think probably 2018, and it is really where they say the PrEP algorithm or predicting outcome improves outcome, or something like the PrEP algorithm improves outcome in stroke survivors. And that's where they actually kind of like either had people into much more of a self-management program, but exactly, it's not a named program, but or that I know of, but yeah, the details of it will be in that paper. So again, email me, u.hammerbeck at MMU, and I can send you the details if needed.
Perfect. Thank you very much. Thank you very much for an excellent talk. And I think if everybody that's attended could please evaluate the session as well, and just with 1 being not so good and 5 being excellent, if you can just pop your evaluations in the Q&A box for us, that would be really helpful towards planning any further sessions. But thank you all very much for attending today, and the recordings will be sent to you. If you email Lisa, all the recording of the event will be sent across with certificates. Thank you very much.
Thank you.